Hey everyone, in this video I am treating one of our own, Bridget. She is one of our nurses here and she has been getting neurotoxin treatment for head and neck pain, migraines, and obviously back in her traps for a while now. She was seeing her neurologist for it, and now that she works here, we have kind of taken over her treatment. So you could see I'm just kind of starting with marking out exactly on her traps where those trigger points are. And then once I kind of found them, made sure she was good and clean. And now I'm just going in and doing some needling with lidocaine, and I'm also giving her neurotoxin at the same time. So what we like to do is pull up some plain 2% Lido. We add in the neurotoxin to the syringe. So as I'm going in and needling in and out of that trigger point to break up the muscle fibers, I'm also giving her anesthesia so she's comfortable, and I'm also giving her her tox as well. So you can see I'm picking up and isolating the trap, making sure I'm staying directly in that muscle, going pretty much parallel to the floor, never going straight down, up and in, always keeping my injection pretty parallel. Once you're in that muscle, you can really start to isolate and feel exactly where that trigger point is, and it kind of feels like going through styrofoam. So once you find that feeling, I always just give a little bit more so they're good and numb in that area, and then just kind of keep working in and out until it feels nice and smooth. We are using a 25 gauge 1-inch needle to needle with to ensure that obviously it is strong enough to support the muscle, be able to go in and out of that muscle without breaking off or me having to worry about that. But you can see I'm also making sure that I'm not going all the way to the hub when I am going into the muscle. So I always want to make sure I can see at least a quarter of the needle at all times, never sticking the entire needle in there. You can see I'm kind of working in like a clock-like fashion, so making sure I'm going around the entire trigger point, not just staying in one area, always picking up and isolating. And you can see I've come out a couple of times. Your angle just always isn't going to be perfect. It feels a little awkward from different angles. So if you need to come out of the muscle and go back in, you can absolutely do so. It's better for the patient to make sure that you are keeping them safe, that you are in a comfortable position and able to always be picking up and isolating that muscle. So she has had this done before, so she tolerates it really well. But obviously, I'm always checking in with the patient while I'm doing this, asking them how they're doing, if they feel okay, and making sure that they don't need a little bit of a break. She gets really tight back in this area, so as you can see, it's taking me quite a while to kind of get in there and really break up that trigger point. So just take your time with it, in and out, making sure that all the way around the muscle it feels nice and smooth. Typically afterwards, patients will be pretty swollen back there. It'll almost feel like a lump, just from obviously the trauma to the area, but also the amount of fluid we're putting in to the muscle. So they always feel like a little lump back there. They're going to be pretty tender, pretty sore. So I usually tell patients, make sure you are drinking lots of water. They can take some ibuprofen or anti-inflammatory to help with the discomfort as well. And then you can see now I've kind of moved up to the splenius capitis region. So this area is super tender for her. It's not an area that I love needling. It's usually one that I'll do for a select few patients. But I'm treating it the same way that I was treating the trap. So you can see I'm pretty much going parallel into the muscle, still giving some lidocaine, also giving her some neurotoxin, still using the 25 gauge 1-inch needle, but you can see I'm only putting like half the needle in. in this region and still picking up and isolating that muscle. So always using these safe techniques when injecting. And typically the patients will really start to feel some relief within a week or two. And if they need more, you can give them more at their 2-week follow-up. But we have treated Bridget in the past and we know this is what works for her. So we will wait and see in a couple weeks if she needs any more, but I think she'll be good to go. Thanks so much for watching, everybody.